Hello everyone, I am Dr. Purvasha Narang, an ophthalmologist specialized in corneal transplant surgery. I am sure, as clinicians, you must have witnessed a recent surge in the number of cases of mucormycosis. It is a kind of an epidemic within the pandemic of COVID-19. And as the number of cases are rising, there is also a rise in the diagnostic challenges. Once we have obtained the samples, maybe from an endoscopic biopsy or from the surgical debridement, how do we go further about it? What is the correct method of sending the samples to the lab? Are microbiology and histopathology both required? Is there a quick and simple bedside test which can clinch the diagnosis of mucormycosis early? So in this video, I am going to discuss a few tips regarding appropriate sample collection for microbiology as well as histopathology for diagnosis of mucormycosis. So mucormycosis or zygomycosis, as it was termed earlier, is basically caused by species of Mucor, Rhizopus, Absidia or Cunninghamella, etc. These saprophytes are found in soil, manure, and in decaying vegetative matter. They are usually unable to cause infections in humans due to our strong immune system. However, during this COVID-19 pandemic, opportunistic infections along with mucor have suddenly increased, and those patients with uncontrolled blood sugar or with HIV or cancer or transplant recipients on immunosuppressant medications or those who have prolonged hospital or ICU stays are more prone to develop this infection. The entry of the spores is through inhalation. The fungus may present as rhinocerebro or vital mucormycosis, which is the commonest form. In this, the fungus may invade the brain too. Other sites are skin, lungs, GI, bones, and joints. It may lead to a disseminated infection in the body due to pneumonia too. Also, this condition is called black fungus, which is actually a misnomer, as this is not a dematicious fungus. It is just that these lesions appear black, and on cultured growth, the spores also appear black. So let's go over the 5 practical tips. Depending upon the site of infection, the sample could be a scraping or a biopsy or debrided material from surgery or endoscopy of the lesion. It could be from the orbit, nasal mucosa, sinus, palate, or a bronchoalveolar lavage. Usually nasal discharge and sputum are not good samples as they do not lead to accurate microbiological diagnosis due to low yield. So they should be avoided. Tissue is the best specimen. Deeper the tissue, more are the chances of organism retrieval. Each sample should be sent for direct microscopy, culture, histopathology, and if needed, molecular tests. Care should be taken to collect the specimens under aseptic precautions and in sterile containers. Dry swabs and blood usually yield poor results. Grinding the samples may decrease viability and is not a good idea. All samples must reach the lab within 2 hours of collection. Remember to fill the requisition form completely and include the history and findings too. Direct microscopy is the fastest way to know the presence of a fungus and can be performed in any bedside lab with a microscope. The sample is smeared on the center of a clean glass slide and a drop of 10% potassium hydroxide or KOH is added over it. A cover slip is placed carefully over it at an angle of 45 degrees and lowered slowly so as to avoid trapping of any air bubbles. Always remember to wear protective gear at all times while handling any of these specimens. Under the microscope, focus the slide initially at 10x magnification and scan the slide to identify any field where thread-like hyphae are suspected to be present. Then at the same field, increase the magnification to 40 times and observe the morphological details of the fungus seen. As seen here, mucor is 5 to 15 microns in size and appears like broad ribbon-like hyaline hyphae that are aseptate or pauciseptate and show wide angle branching at irregular intervals. One may enhance its detection by adding calcofluor white and observing under fluorescent microscope if available. Sample may also be sent on another slide for gram stain. If microscope is unavailable, then sample can be sent in sterile normal saline. A gram stain slide is screened by 40 times magnification and visualized under oil immersion and 100x magnification too. It may show similar features, and this helps us to differentiate between mucor and aspergillus, as both are angio-invasive fungi. As seen here, aspergillus has thinner hyphae, regular septations, and acute angle branching. The specimen should always be sent for microbiology culture, as culture helps in identifying the type of fungus grown. Sample can be placed on Saburo-dextrose agar or potato-dextrose agar and is incubated at 37 degrees Celsius. If media is not available, then specimen can be transferred in sterile normal saline to the nearest lab, but never in formalin. Colonies of mucor are generally fast growing, that is within 2 to 3 days. These fluffy colonies could be cottony white or greyish black due to their spore formation and have salt and pepper appearance. Further confirmation of species may be done by the lactophenol cotton blue preparation. Large and round sporangia are seen at the end of each branched sporangiophore. The sporangia are thin-walled and rupture to release the spores. Mucor doesn't show presence of rhizoids and can be used to differentiate it from Rhizopus and Absidia. On histopathology, one may determine the presence as well as invasiveness of the fungus. The specimen is sent in 10% formalin solution. Usually, hematoxylin and eosin stain this fungus well as against aspergillus. Apart from the typical hyphae morphology seen under direct microscopy, one can observe vascular invasion, thrombus formation, granulomatous reactions, tissue infarction, and necrosis too. One may try periodic acid Schiff stain or Grocott methenamine stains too. Deeper tissue sections may show more organisms. However, histopath reporting may take at least 4 to 5 days, and this is generally a confirmatory test while one has already started the patient on appropriate antifungals. Molecular methods and serology are purely adjuncts and usually not necessary unless the diagnosis is not confirmed or one suspects mixed infections. PCR is not available widely for this and is in experimental stages. The Molditov spectrometer can be used to identify the fungal species. And serology markers like galactomannan and 1,3-beta D-glucan, if found positive, rule out mucormycosis as against aspergillosis. Finally, a clinician has to remember that mucormycosis is a life-threatening disease and appropriate therapy should be started as early as possible based on history, clinical suspicion, and microscopy findings. A multidisciplinary team approach is preferable. Also, if this disease has been made notifiable in your district, then appropriate reporting to the local authorities should be done once the diagnosis is made. This is the summary. I hope you found this video on the lab diagnosis of mucormycosis helpful. Please feel free to leave your suggestions or queries related to the topic in the comment section below. And I do hope that with these practical tips, we all will be able to manage mucormycosis better. Thank you and Jai Hind.